ECG stands for electrocardiography. An electrocardiogram records electrical activity of the heart. It records electrical signal across multiple heartbeats and produces ECG strip. It is the simplest and fastest test used to evaluate the heart functioning. So, it is most common test in case of MI and angina. At first, in 1842, Italian scientist Carlo Matteucci realized that electricity is associated with heartbeat. But ECG finally was discovered by William Einthoven. So, he is called as the father of ECG. In 1906, using the string electrometer ECG, William Einthoven diagnosed some heart problems. He was also awarded with a Nobel Prize for Physiology and Medicine for his work on ECG. Majority of hospitals use 12-lead ECG in which 2 are bipolar limb leads, lead 1, 2, 3. 3 are augmented unipolar limb leads, AVR, AVL, AVF. 6 are precordial unipolar chest leads V1, V2, V3, V4, V5, V6. Unipolar and bipolar limb leads record electrical activity of the frontal plane and augmented unipolar chest leads record activity of the horizontal plane. It is important to remember that the 12-lead ECG provides spatial information about the heart's electrical activity in 3 orthogonal directions: right to left, superior to inferior, anterior to posterior. For this we have to place 10 electrodes. From which 4 on limbs, right arm, right leg, left leg, and 6 on the thoracic region. V1 should be placed on the 4th intercostal space to the right of the sternum. V2 on the 4th intercostal space to the left of the sternum. V4 on 5th intercostal space at mid-clavicular line. V3 directly between V2 and V4. V5 on the level with V4 at left anterior axillary line. V6 on the level of V4 and V5 at mid-axillary line. Apply lead 1 to the left arm. Next, apply lead 2 to the right arm. Then, connect the left leg. Place the electrode slightly above the ankle. This electrode placement is the reference for all the augmented leads. Finally, apply common on the right-hand side ankle. This connects to the ground input on the recovery device. Lead 1, AVL, V5 and V6 look at the left lateral side of the heart. Lead V3 and V4 look at the anterior side of heart. Lead V1 and V2 look at the intra-atrial and intraventricular septum. Lead 2, 3 and AVF look at the inferior side of heart. As with the limb leads, the chest leads each show a different ECG pattern. In each lead the pattern is characteristic. The cardiac rhythm is identified from whichever lead shows the P wave most clearly, usually leads 2. When a single lead is recorded simply to show the rhythm, it is called a rhythm strip. But it is important not to make any diagnosis from a single lead, other than identifying the cardiac rhythm. Next are the components. So, it is waveform components that consist of the electrical events during one heartbeat. Waveforms are P, Q, R, S, T and U. ECG paper has thin and thick lines. Thin lines are at 1 mm intervals or 0.04 seconds. Thick lines are at 5 mm interval or 0.20 second. One thick line box contains 5 small boxes. So, it is 0.20 second or 5 mm. So, 5 thick line boxes which are 25 small boxes is of 1 minute. In the y-axis 10 small boxes represent 1 mV or 10 mm. So, in simple words, horizontally a small box is of 0.04 second and one large box is 0.20 second and vertically one large box is 0.5 mV. The baseline of ECG tracing is called isoelectric line and denotes resting membrane potentials. Electrical activity towards a lead causes an upward deflection and electrical activity away from a lead causes a downward deflection. Next are the components. P, Q, R, S, T and U. First is the P wave. P wave represents depolarization of both atria and time taken by atria to empty their blood into their respective ventricles. It is the sum of right and left activation. The right atrium is activated first since the pacemaker is located in the right atrium and then left. First positive half represents the right atrial activation as the electric impulse comes towards the lead V1 in the right atrium, and the second negative half represents the left atrial activation as the electrical current goes away from the lead V1 in the left atrium. Therefore, it is negative. The duration of the P wave is less than 0.12 seconds and 3 small boxes. Amplitude is less than 2.5 small boxes. P wave or atrial abnormalities are best assessed at V1 and inferior leads, which are lead 2, 3 and AVF. Next is the QRS complex. The QRS complex is the major positive deflection on the ECG with sharp peak. The QRS complex is produced by the depolarization of both ventricles. It is the combination of the Q wave, R wave and S wave. For example, the normal QRS complex in lead V1 does not contain a Q wave, but only R wave and S wave. Yet the combination of R wave and S wave is still referred as the QRS complex for this lead. Firstly, Q wave. The Q wave represents the normal left to right depolarization of the interventricular septum by the septal branch, which originated from the left bundle branch. Now, it is a negative wave because the interventricular septum is supplied by the left bundle branch. And the left bundle branch stimulates the interventricular septum in the opposite direction of cardiac impulse. Q wave is not visible in all ECG leads. Physiological Q wave may be observed in leads L1 AVL, V5 and V6. A physiological Q wave doesn't exceed 0.04 seconds per 1 minute in duration. Deeper Q wave more than 2 mm may be seen in leads 3 and AVR as a normal variant. They do not exceed 1/4 or 25% of our wave height. Q waves are considered pathological if depth is more than 2 mm and more than 1 mm wide. Pathological Q wave usually indicate current or prior myocardial infarction. Absent Q wave in leads V5, V6 is most commonly due to the left bundle branch block. Next is the R wave. R wave is the first major deflection in QRS complex. It is upright in most leads except AVR, where the P and T wave are also inverted. In limbo leads, R wave voltage is normally at least 5 mm, while in the precordial leads, R wave voltage exceeds 10 mm. Under normal circumstances, the R wave voltage gradually increases as we move from lead V1 to lead V6. This is known as normal R wave progression in precordial leads. Less than normal value, the QRS complex, is known as a low voltage complex. In the lead V1, R wave is 4 mm, while in lead V5 and V6 is 25 mm. So, the R wave is smaller than the S wave in the lead V1, and the R wave is taller in lead V6 than S wave. In leads V5 and V6 it reflects left ventricular activation, while in lead V1 and V2 it reflects right ventricular activation. S wave represents depolarization of Purkinje fibers. The S wave is the first downward deflection of the QRS complex that occurs after the R wave. An S wave may not be present in all ECG leads in a given patient. In normal ECG, there is a large S wave in V1 which progressively becomes smaller to the point where almost no S wave is present in V6. In leads V1, it is less than 27 mm in depth, and in V6 less than 7 mm. T wave represents depolarization of the ventricles. It is upright in most leads except AVR, L3 and V1. It is taller in V6 than V1 and taller in L1 than in leads 3. It does not exceed 5 mm in height in the limbs leads and 10 mm in precordial leads. Next is U wave. U wave is small deflection of 0.5 mm, usually in the same direction as the T wave. It is best seen in V2 and V3. The source of U wave is unknown. It may be due to delayed repolarization of Purkinje fibers or prolonged repolarization of mid-myocardial M cell. Voltage of U wave is normally less than 25% of the T wave voltage. Thank you for watching this video and stay tuned for next part of ECG.